I now will make very few remarks and then open the floor for discussion. I request you all to keep your questions brief so that the authors can reply. I just want to flag a couple of very interesting issues, I think, and we had a lot of complimenting of people raising conceptual and theoretical dilemmas within this area called governance. And the fact that public health very often uses governance as yet another technical tool to fix systems. So I think we have a very rich set of presentations, and I'm not going to summarize that. But I just want to say that what struck me from this presentation is, the set of presentation is that there is a plurality and diversity of evidence with aspects of governance. And I think somewhere, how do we pull all this together to make sense of what is happening? Second, I was very interested to find out from Srilata that you had politically a move under the Janta government for decentralization in Karnataka. Now, what impact did it actually have on health systems per se? Is it the same or is it different? And I think you can learn a lot of lessons for UHC from there. The experience of planning process, Anuradha, which you talked about, the various lacunae, even though you had a mandate with the NRHM to do bottoms-up planning, what yours showed is that there were several lacunae and gaps in the processes. And I want to then speak to what Raman presented. What have you really done in terms of gleaning this evidence to speak to your toolkit which you presented? And I felt that the important concept of power, the concept of power and its circulation is something that needs to be really in the background when you're talking about issues of governance, which in fact Sudarshan really elaborated. We very often look at governance as something which is district and below, but we are not looking at governance as starting from the top and not just relegated to the Ministry of Health or health systems. I think there's a larger issue of a governance deficit which we need to take into account. With those few remarks, I request you to please ask questions. Anne and the person in the back.
Thank you very much, and thank you to all the speakers for a very interesting set of presentations. I had 3 comments on 3 of the presentations. The first to Kabeshek, really to ask to make the point that in many countries doctors aren't a homogeneous group, and so that I think if you haven't done already, it would be really interesting to explore the differences in the different groups of doctors, whether that's urban or rural or specialist or non-specialist or whatever. I think on for Srilata Rao, the decision space issue, I mean, I wonder whether the way forward is to try and get relatively simple quantitative information on a large number of districts, so you can start doing more statistical work on it, and then when you have a small number of observations, do much more in-depth qualitative type analysis, because I think to try and do quantitative analysis on relatively small samples is really difficult. And I think some of the interesting work, for example, on government effectiveness that's done with the, is it the CPIA effectiveness indicators, is really interesting. And I think one of the great advantages of India is that you do have this possibility to compare across states, to compare across districts. You have large sample sizes. Admittedly, you have to get simple indicators when you're doing it at that level. But I think thinking about a large-scale quantitative analysis and small-scale in-depth analysis, I think is a good way forward. And then finally, Anuradha Jain, on the planning processes, I wondered to what extent you'd looked at what is now quite an old literature on planning, because what you were saying really reminded me of the planning literature of the 1970s and 1980s that looked in depth at the implementation of planning processes. And indeed, I started my career by doing that in the National Health Service. And that literature does point to the fact that plans are often not followed. And I think it does give some hints as to how do you alter planning processes in order that they're more effective. I think we can still learn from what's been done, even if it's some years ago. So if you haven't looked at that literature, then I think it would be interesting to do so. Thank you.
Yes, please. We'll just take a couple of questions and then I'll have the authors.
I'm Ruhi Se, with the Cochrane Public Health Group and Oxford Policy Management. I had three comments come questions sort of thing. The first was directed to Raman. With regard to this whole toolkit which has been developed, now is it the case that the HLEG's recommendations are sort of accepted and going to be implemented, or I was under the impression that there was some contradiction with what the Planning Commission is suggesting? That was the first. With regard to all the changes that you are sort of talking about in the toolkit, very correctly it points to the long time frame needed and the fundamental changes that are required, and Anuradha's presentation also points to the different things need to be changed. But all this seems to suggest what Rama already said, which is that it's broader. You can't have these changes in isolation in just the health sector. The whole district implementation agency structure, the whole sort of governance structure seems to be what needs to be corrected. And with regard to corruption, while Mr. Sudarshan did talk about corruption in the private sector, particularly with regard to health, is it the case that this corruption in the health sector can really be removed out, weeded out, even if there's regulation, if there is no regulation and reforms in the health education sector? As Mr. Madan Gopal said yesterday, if some medical graduate is paying 7 crores for a radiology seat, what can we expect then?
Okay, would you like to respond?
No, I mean, I don't have much of a response. I accept Anne's comment that there should be much more appreciation of heterogeneity. And actually, I'm making a presentation on human resources later in the day in which I address exactly that issue, but didn't really have time to go into that, but I appreciate the point.
Professor Miller, no, we haven't looked at the 1970s literature that you're talking of. But one of the authors is a very senior person who has gone through a lot of literature herself. So she must have taken herself, but honestly speaking, I personally haven't gone, and I have just depended on my personal experience for the last 4 or 5 years in the field. Thank you.
I completely agree with what you said, Anne, because what we're finding is that there are many, actually many questions, more questions being thrown up by the research than answers. And I think in order to answer those, the original as well as the additional questions, we'll have to go and spend time talking to individuals, because this is extremely based on individual capacities, individual perceptions. And until we get a sense of that, it's going to be very difficult to aggregate and begin to understand what the principles are behind some of these responses that we're getting, you know. So the qualitative aspect in the 6 districts that we're already planning is definitely on the cards. And then expanding it to other districts to get more robust quantitative data is certainly the next step. Thank you.
About corruption, initially I used to talk about eradication of corruption in health services. Now I have mellowed down. Even I will say control of corruption. It's a chronic illness like tuberculosis. It's not like smallpox, so it's only control. Second, about medical education corruption, I had a slide, I didn't show it. It's very, very rampant. It's not only about the capitation fees for the, as health secretary said yesterday. Have you heard of what is called not to fail amount? This is happening in private medical colleges. Every student has to pay 30,000, that was about 6 years ago, 30,000 rupees, all the students, those who are merited, everything. If you want a special marks in a particular subject, that's a different package. Every student had to pay 30,000 rupees is called, what is called not to fail amount. So this is the type of medical education. And it happened to be one of the local superintendent of police daughter was in a private school. She comes and tells, tomorrow you have to pay me 30,000 rupees. I know you are in Lokayukta. If you tell Lokayukta, I'll commit suicide. It will not solve my problem. So she was also blackmailing his police father. So he came and then we found it was true. We called the vice chancellor, postponed the exam, but we found it was true. This was not to fail amount. There is corruption in the medical education, very true.
Yeah. The second remark that you have made about, the need of institutional and structural changes at different levels, that is inevitable. I agree to what you told. With reference to the HLEG recommendations, whether they have been accepted or going to be implemented. That is something, yeah, of course that particular question is something very relevant and it is roaming around across planning commission, ministry and all. And also there are a lot of debates about what has been accepted and what has not been accepted. What is the USC that the planning commission is talking about and what the HLEG was talking about, what the civil society groups were talking. See, these issues are definitely there, but these all are about the interpretation of what has been said. So there is an ample space for going for a toolkit. That's what we thought. At least, whichever is getting accepted, you have to have preparatory measures for doing all of them. That's all. Thank you.
No, it's just a point that, regardless of whether the recommendations do get taken up, we feel that spelling out an implementation pathway can actually make the argument for many of the HLE recommendations more persuasive, because it grounds it in a real health systems perspective. And also this instance that you mentioned about that we need holistic reform and not just in the health sector. And I think we've seen in many other countries, including Brazil, that health can be an example of good governance. So even setting that example can be useful for other sectors.
Are there any other pressing questions? Yes, this will be the last. Yeah.
Within the country, within the state or within the region, you see that most of the cases we find that the health facility, health system seems to be more good performance, but some other state, some other region seems to be less. What should the government should play in this study? Because most of the evidence are supporting for this. What is the role of the governance in that sense?
So what you're trying to say is that some facilities perform better and some facilities perform worse, and what role can governance play in improving performance?
No, in the different section or different region, that most of these states seems to be better function in health facility and health structure, but some of this state or some of the regions seems to be less.
Okay, so you're saying that there are interregional variations in health outcomes. Yes, that's certainly something that's been studied quite extensively in India, I think, and there are certain states that in fact have been given a special status so that they can get additional help, additional support in order to strengthen their health systems. Why is that the case? There are many, historical reasons to do with available capacity to implement programs, political will, social determinants that shape health outcomes and use of health services. So it's a very complex area, I think, and there have been attempts on all those fronts to try and improve health outcomes in those states. I'm not sure if somebody wants to add to that.
If I have understood you correctly, what you are trying to say that while some health facilities do perform good, while others don't. So what is the role of good governance? Actually, the fact that some health facilities work better or work good and some others don't is indicative of the failure of good governance. The fact that you don't have governance at a systemic level, that is why you have this kind of places where the success is actually attributed to ad hoc, informal arrangements, individual commitment, which actually evolves through different kinds of contextual factors. If you have good governance, then you will not have these kind of things. It's transparent, it's systematic, and all facilities ideally should perform the same manner. Yeah.
On that note, thank you very much to all the speakers and the keynote speaker. And I'll just close the session now.